I would like to now request Dr. Madhan to come and talk to us about the use of focus in chronic ankle instability. Thank you very much.
Thank you, Claire, and thank you, Vaibhav, for an excellent presentation, as well as Ajit. It was quite nice to follow through from where you guys left. I'm just going to share my screen now, and I will talk you through the way how I would go about assessing an ankle joint. Just want to make sure everybody is getting my screen nice and clear. So when a patient comes with an ankle problem, they have you've done your basic assessments, and then you want to look at the options of what are the investigations you need to do, and do you want to differentiate between a structural instability and a functional instability, and you're unsure that what is the immediate line of assessment you can do. My go-to tool is diagnostic ultrasonogram. And I think in my personal experience in the last 5 years, it's been one of the important tool in my outpatient clinic. Anybody coming with any musculoskeletal problem, I will tell you why. And it's also from a research point of view, the diagnostic ultrasound, MSK ultrasound, is gaining popularity. If you guys follow Twitter, there is a big group in Australia, the ultrasound group by Daniel Wakely, who does a lot of great stuff, as well as there's a lot of information that's coming out there with regard to point of care ultrasound in musculoskeletal medicine. So why ultrasound? When we discuss about ultrasound on soft tissue injuries around the ankle, it's produced better accuracy than MRI, especially ligaments, tendons, and joint evaluation in compared to MRI. However, in saying that, as Ajit mentioned, there is a limitation of ultrasound with any diagnostics tool, and the real limitation is you can't see the cartilaginous structures very well. So bear that in mind. The most important thing for me with reference to chronic ankle instability is the ability to dynamically evaluate your ligamentous structure by stress testing your ligament while the patient is in your outpatient clinic or in your physiotherapy clinic. Thereby, ability to come with a diagnosis of, is there a structural defect that requires repaired, or the ankle instability you're encountering in your patient is a functional one. In saying that, by doing that, you are minimizing the unnecessary referral further down the line with regard to MRI evaluations and a consultant opinion with regard to thing, and then come back into the circle of, right, the patient needs to go through a good 3 to 6 months of good ankle rehab with bracing and graded exercise program that includes balance, proprioception retraining, strength retraining, stability retraining, and return to running, and return to change of direction and explosive strength and power. And another important thing for me is a very cost-effective clinical assessment in line of when you're ambiguous with regard to you are not exactly sure what's going on. Also, it helps you to pick up sometimes a serious differential diagnosis in rare cases. What could mimic like an ankle instability could be something else. It could be there could be additional tendon sheet swelling, additional a tumor might mimic like an ankle issue, and the ultrasound gives you that ability in a point of care situation, and that's where I think it's my go-to tool. So you could ask me, okay, you are talking about ultrasound. Not every clinic has an option of having an ultrasound scanner, but what is the evidence if I want to invest one and then start upskilling and training myself into using it as a point of care tool? There is a systematic review done in International Journal of Sports Physical Therapy, evaluates the effectiveness of ultrasonography in diagnostic, especially chronic ankle instability. And it says that in comparison with arthroscopy, the ultrasound has a sensitivity of 98.9% and specificity of 96.2%. Also, when measured against the arthroscopy in comparison with MRI, ultrasound had a sensitivity of 93 to 8.8% and 100% specificity, which is pretty good with regard to just a point of care assessment where you are not spending a large amount of money for a static assessment with an MRI scanner to evaluate an ankle ligament / tendon injuries. So just to make sure we all understand, it's a very easily doable procedure. I'm sorry, due to Zoom and as well as the video thing, I didn't put a video in here. It's important to understand and systematically evaluate the ankle joint using an ultrasonogram. And when we look across in the ankle anatomy, the most common structure that involves ankle injury is the anterior talofibular ligament that leads to anterolateral instability. And often that's the most common ligament that end up getting repaired along with calcaneofibular ligament. So in this diagram, I've just given a schema of what is the orientation of both ligaments are and how they will look under ultrasounds when you do an assessment. When the ligament is intact, you'll have a lovely the lateral malleolar cortical surface as well as a talar surface with a good, nice hyperechoic structure bridging across both thing. Underneath, you'll see the ankle joint space. That's a well intact ligament of an ankle. And this is a static assessment at that point of time. You know that when you can see a nice hypertrophied hyperechoic line in the ultrasound, you know that the ligament is intact. However, the ligament might appear intact in a resting position if there is an intrasubstance tear in the ligament, and you want to evaluate that intrasubstance tear is when you put in a dynamic load position, that ligament is kind of overstretched and there is a gap in the ligament. So you can incorporate dynamic assessment. So in this position, when you have an ultrasound, look across the lateral malleolar and the talus position and the ligament. And when you do a stress test, you can actually measure the distance as well as see the expansion of the ligament with intrasubstance tear. So it's a very easy, in that case, if you're treating an ankle problem with, when you do a draw a test, the ligament is kind of not only overstretched, but you can see intrasubstance tear at the same time excessive mobility. On that point of time, you can actually make the decision whether you want to think conservative or further down the line, the patient need to have a surgical opinion. If you look across the calcaneal fibular ligament, again, it's also, along with evaluating calcaneal fibular ligament, you can also evaluate the peroneus brevis and peroneus longus tendon, and also look at the integrity of the ligament. So in this schema, while doing a neutral, the ligament might, in a neutral position, the calcaneofibular ligament is slack, because in neutral position, there is no stress goes through the calcaneofibular ligament. But when you had an active dorsiflexion, the ligament torts across the lateral malleolar talus and calcaneus, where you can see a nice hyperechoic line on the ligament. But if you have a ligamentous injury, sometimes you could see what we call as a peroneus brevis sinking sign. The peroneus, there is a dark void area, and the peroneus brevis tendon would sink into the joint space. In that case, you know that you're dealing with a lateral calcaneofibular ligament tear. So to keep it in perspective, as an elite sports physio, it's important that whenever an athlete comes in, I want to have a thorough assessment. And at the same time, at the beginning of my assessment, I would really like to have a very comprehensive plan of action, where thereby I have an idea about what is my diagnostic options, what is my prognostic limitations, how long will it take for me to get these athletes fit to get back into training and get back into play. And further down the line, if I need to have a surgical opinion, why is the reason for that thing? And it becomes an essential primary tool in your primary practice. So it's very important to look into it as an upskilling thing. And I think, in my opinion, of practicing diagnostic ultrasound over the last 3-4 years, it has become a part of my essential assessment with regard to patients suffering from anything from shoulder, ankle, knee, wrist and hand, as well as lateral elbow and ankle. It's an integral part of my primary physiotherapy assessment, where in my first contact with the patient, along with the good subjective history, with the objective non-investigative assessment, I do a routine ultrasound evaluation of the ankle in order for me to differentiate a structural, am I dealing with a structural instability of a patient, which requires, rather than along with physical therapy, if required surgical options, or it's a functional ankle instability where I can actually reassure the patient in order to progress them into a proper rehab program that has specific goals at specific stages. As I say, my talk is probably the short and briefest of the all. All I would say is keep calm and let the physio handle it. Thank you, guys.
Thank you, Dr. Madhan. I am going to keep that last slide, put it up at work.
I think I hand the session over to Dr. Claire for rehabilitation of ankle, and let's take it from there.
Thank you very much. I think you need to stop sharing your screen.
Yeah, just 1 second. I'm just going to do that, but for some reason, it's as always with Zoom, it does its own thing. Right, stop sharing. Done. Fantastic.
Beautiful.
Here we go, Claire.
Thank you very much. I hope my screen has come up for you all. I'd like to thank Scientifica team very much for inviting me to come and chair this session today. That's a very great privilege for me. I'm sorry that it's online, and I'm sorry that I can't be there. It's been a few years since I've been able to be in India and at Sanchedi. Okay, so I get the job of talking to you about chronic ankle instability, the rehabilitation. I'm going to do a very quick background and assumptions, and then I'm going to talk mostly about using the chronic ankle instability model to direct your rehabilitation, a quick thing on braces, and the PASS framework. Why do we care? This is the closest I could get to looking at chronic ankle instability in India, which was a study we did a few years ago in Sri Lanka. And you just need, all I want to draw from this slide is that really, even though there might be ethnic differences and cultural and country differences, really chronic ankle instability is a problem, not just in the Western world. How do you get chronic ankle instability? Well, there's actually 4 hypotheses about this. One we've already had mentioned to us today, which is that so many people consider an ankle sprain to be a trivial injury. They don't go and seek any formal care at all, and they just live with it. Another hypothesis is that sometimes the care is too passive. So people do actually go and seek care, and they get, well, in Australia, they get ice, elevation, and sort of say to you, well, once you can hobble around on it, that's fine and it'll get better by itself. Or the opposite, which happens mostly in athletic populations, which is the game is really important. We have to get you back on the field, and you get returned to activity too soon. The third hypothesis is that as part of the rehabilitation or in your recovery time, you end up recovering and having aberrant motor patterns. We're going to talk about this quite a bit more. There's only been one study so far that has actually prospectively looked at people who had a lateral ankle sprain and who went on to develop chronic ankle instability. And they found that people who had impaired jumping and landing at 2 weeks went on to have problems, and that people who still had trouble with the balance in the star excursion balance test and had lower FAM scores at 6 months also went on to get chronic ankle instability. And the 4th hypothesis is genetics, which there's more and more research coming out about. The things that we can deal with in the rehabilitation space is the first 3. I'm just going to say here that I'm making the assumption as I go on through this talk that you have ruled out anything else being the problem with your patient who's in front of you. Okay, so the most important thing I want to say is that you should only rehabilitate what is impaired. It's so easy, particularly with ankle sprains, that we get this little formula of treatment going on, and we treat everything, and then off we go, and we haven't actually addressed the patient's problem. So the latest model of chronic ankle instability is from Hurdle and Corbett. It's an excellent article. I really recommend that you read it. And it takes into all the things that can influence somebody in the development of chronic ankle instability, and therefore all the things you need to look at and consider while you are planning your rehabilitation. The main 3 things that I'm going to talk bits about today are the pathomechanical impairments, the motor behavioural impairments, and the sensory-perceptual impairments. But as we've talked about already, you know that the context of your patient is important. There are personal factors. We've talked about genetics, but there's things about the person and what they believe and what they think and what their situation is, what they can afford. And then there's environmental factors, which also play a part in what's going to happen. And the model comes out and says that you have to take all of these things into account And you end up with a spectrum of chronic ankle instability severity at one end and a coper, which is somebody who's had an ankle sprain and fully recovered at the other. And there's a whole spectrum in between that you need to be aware of. So if we think of pathomechanical impairments, one of the main ones that has already been mentioned is the arthrokinematic restrictions. And in chronic ankle instability, it comes in with a restricted dorsiflexion often, which means that one of the things you're commonly going to find is having a restriction of your AP glides, and you must never neglect the associated joints, which can also have restrictions such as the subtalar joint and the mid-tarsal joint. Really important to look for the arthrokinematic restrictions. If you have a restriction there, which ends up in a range of motion restriction, which means that you change how you walk or you run, which will therefore change your muscle activation and your muscle strength, and therefore you'll end up with aberrant patterns, many things that can go wrong. Osteokinematic restrictions, well, I've already talked about that. Look for the restricted dorsiflexion. For whatever reason that the restricted dorsiflexion might be there, which might not just be arthrokinematic. Oh, sorry about that. Then we have sensory-perceptual impairments. These are the things we're often used to dealing with as physios. You're not getting good input from from your sensory system. Poor proprioception. It's been shown that sometimes poor cutaneous sensation is related in people with chronic ankle instability. And the ability, therefore, for the person to integrate their sensory inputs can sometimes be impaired. So it's really important to think about these things and to test out. Mostly we do it through, I'm not going to talk about that, balance, but you need to think about this. I'm going to mention pain as well, because even though pain is actually quite common in chronic ankle instability, it hasn't been talked about a lot. And one of the interesting things that's come out of some research that's come from our lab is that you need to check for centralization of your pain. So we have run a study recently where we had people with chronic ankle instability with and without pain. And one of the really interesting things that you will see from here is that it was the people who had pain of 5 or greater who really, they couldn't correctly identify the limb when they used the limb recognition task. They had more movement of their foot when they were standing in a single leg stance. And when we did the sensation testing, either by pressure pain thresholds or by conditioned pain modulation, there was a big difference. The reason I'm raising this now is it's not something we think about with our patients with chronic ankle instability, particularly because these people who were said that they had 5 out of 10 pain, they didn't have constant 5 out of 10 pain all the time, which is what we think about when we think about people having central sensitization. So if you have somebody with more than 5 out of 10 pain, have a look through your other things to see whether they've actually got some central sensitization happening. And then, of course, as part of the sensory-perceptual impairments, you need to know what is the person's perception of their instability. Do they have kinesiophobia? Is it affecting their health-related quality of life? Has it affected their physical activity? And we measure most of that by using the patient-reported outcomes. Then we have the things we're used to, the motor behavioural. Muscle weakness. Muscle weakness is so common. Particularly in chronic ankle instability, it seems to be eversion, but you need to know that often they have proximal knee and hip issues as well. So you're not just going to check out around the ankle, you're also going to check out around the knee, and you're also going to check out around the hip, because the weakness can occur anywhere. Balance, we're also familiar with. Steer away from just doing static balance. Make sure you're doing dynamic balance, and really importantly, as part of the integration, add your cognitive loads. One of the things that is really important in chronic ankle instability is that people lose their ability to coordinate everything, getting in the sensation, coordinating their motor behavioural things, and then being able to cope with something else happening at the same time. So whatever you've got to get somebody back to, think about what sort of cognitive load are they going to have, and start adding them into your rehabilitation if you find that that's what the issue is. And altered movement patterns. Well, I'm not going to go into that because most of the things about altered movement patterns come from 3D biomechanics labs, which is not terribly helpful in the clinic. But you need to be aware that, as I've said before, if you have an impairment in one particular area and it affects your integration, it's probably going to affect how people are walking, running, cutting, jumping, or doing whatever. So you need to be aware of that and watch for things that people might be doing. Altered stride length patterns, change in the positioning of the foot. It's getting easier these days with more things on apps so that you can actually videotape people and look at it in slow motion. But be aware that this is what happens. So when you put it all together, the perception, integration of perception and action and the neurosignature is really important in chronic ankle instability and how it all fits together. So have a look at all of these things and see what your patient is having an issue with and what it is that they've got to get back to, and that's what you need to address. Now, I wanted to have a quick thing about braces, because often we use taping and bracing to help prevent recurrent injury. And one of a systematic review that we've done here, which is about prevention of recurrent injury, you can see that whether you use a tape or a brace and whether you use ankle sprain directly or ankle injury, which is mostly ankle sprains, they are really effective at preventing injury. So they're definitely something that you should be considering using with your patients. And one of the really interesting things is that if you look at the odds ratio of having an ankle sprain, a recurrent ankle sprain against your number needed to treat, a brace is actually more effective than tape. So something to bear in mind if you are working in a team sports situation, and you can afford it, obviously, but bracing seems to be more effective. And now I'm going to briefly have a talk about the PASS framework, which is a framework put together by an international panel of, by a Delphi process of medical experts internationally across, I can't remember, 19 countries, I think it was. And these were people who were working with national teams. And what are they recommending for returning your person? You need to know about their pain during their sport or whatever activity you're trying to get them back to in the last 24 hours. If they've had pain in the last 24 hours, they shouldn't be going back to sport. Ankle impairments, we've just been through that. Do they have the range of motion, strength and endurance and power for whatever it is that you're trying to get them back to? Athlete perception. How does the athlete or your patient feel about their ankle? How do they feel? Do they feel that they're able to do what they can? Are they confident in their ankle? Does it feel stable? Are they actually ready for going back to sports psychologically? Some people are not. Sensory motor control. What's their proprioception like? What's their dynamic postural control like? What's their ability to add a cognitive load to what they're doing, which is what's going to happen to them when they're doing their activity? And what about their sport performance? Can they do the sport-specific or activity-specific drills that they need to be able to do in order to do the activity that they're turning back to? A lot more information can come from the Ankle Consortium's Rehabilitation Oriented Assessment, which is in the British Journal of Sports Medicine in 2018, which will also help you when you're thinking through what are the impairments that you have with people with chronic ankle instability. So diagnose specifically, be sure you know what the problem is, treat specifically as in look at all the things that could be affected in people with chronic ankle instability and only rehabilitate the ones that your patient actually has the deficit in, making sure you're returning them to the activity and level that they want to. Never think in the clinic that it's just a sprain and it will get better eventually, because it doesn't always happen. Thank you very much.
Perfect. Thank you, Claire. I think, Claire, as a chair, I would like you to lead the panel discussion and ask specific questions with the panelists, and would be nice to have a little discussion. And if any audience have questions, then we can all try to answer to our level best and take it from there.
Thank you very much. Yes, please, if there's anybody in the audience who would like to ask specific questions, do post them. So I am particularly interested, since we all had to gallop through so quickly, to ask the rest of their panel, if you only had 2 or 3 minutes with somebody, do you have a go-to clinical thing that you use as your main, diagnostic or issue for your patient that's in front of you?
Yeah, so let's start with me, because I've started the discussion and I had to wind up like pretty quickly. So there's nothing in particular. I probably would still go back to taking a brief, detailed history, because that gives me enough information. And clinical assessment obviously will help me understand the situation a little more. What happens usually in athletic population is it is more of let me just put it in this way. What worries me more is any athlete wants to get back to sport as soon as possible, and helping them understand that those last bit of return to sport is very, very important, and they need to have patience. That exactly where kind of there's a little tussle between the athlete and my team, where we try to understand and help them get. But as again, answering you, going back to answering your question, clinical examination and the recent history is something that is very, very important for me to help them understand, help the athlete or the non-athlete to understand things a little better.
Thank you.
Right. Let me just take it through in continuation to what Ajit said. Yes, definitely the history, a quick history, which is going to help me out. And if I have only 2-3 minutes, I would basically do a little bit of functional kind of an evaluation, which is basically making the person stand there and look at his ankle. I mean, if there is any kind of pain, if he is able to stand on both feet or one feet, that will give me quite a bit of depth into where the ankle is coming from. And of course, the history quickly as I'm talking to him will be the best thing, because even if you talk about 2 or 3 minutes, I mean, being a sports physio, we run onto the field and we want to see an ankle. We of course would have to check if they are able to stand and continue the sport. That's the most important thing. And if that is not going to happen, that's my quickest way to learn about the ankle.
Thank you very much.
I think from my point of view, I would agree with the same. There is nothing called a quick assessment tool, but it's always, as you said, keep it very specific to the patient. Are they able to do the function they require to do for the demand of activity of the sport they're deemed to participate in the next hour or so? And that usually means a very quick functional assessment of ability to weight bear, ability to just calf raise, ability to just take the load tolerance. I think these are the 2-3 characteristics for me. If they don't have these 3 characteristics, that's my quick assessment tool. But again, as I said, treat the patient, treat the impairment, not treat the scans and x-rays and MRI is my way of going it. And I always say, I think in all of us worked in with athletes we're still working with athletes. I think the key thing is the confident the clinician is the confident athlete in terms of making a right decision of how they want to go about it. I think it's very important to educate and empower the athlete in terms of risk and reward options, and then let them make the decision, involve them in the shared decision making on their own care. That would be the best way to go about it.
Thank you very much. Okay, we have one question from the audience. Whether you think that the presence of flat foot in athletes can make them more prone to chronic ankle instability, and if there is any correlation, will normal chronic ankle rehabilitation management help in similar fashion, or are there any modifications in management?
Who
want to tackle that one?
Anybody? Yeah, quickly. I mean, I definitely, as I said, I definitely give a lot of emphasis on flat foot or other pronation, because that contributes to recurrent injuries a lot more. And practically, obviously, just giving them orthotics, a proper customized orthotics has helped them immensely. So yes, I would definitely look into considering flat foot as one of the factors to deal with.
I think in my experience, what I've found is, I think correlation is not causation. Sometimes it's important to look at the lower limb kinetic chain as a whole. And if somebody has a congenital flat foot and well adapted flat foot, often I find these athletes, I think the only time we see them flat foot as a problem in my experience is when they get injured. But in the normal circumstances, if you look across their history throughout the development, I've seen quite a lot of well-pronated, flat, functional flat feet, bilaterally adaptive flat feet without much of an ankle issues. So it's, again, I would agree with Ajit, if it's definitely a contributing thing, but it's not in isolation. It's important to look at the picture as a whole. And then also, I think it's very easy to give them an orthotics, but if you're not going to give them an adequate kind of an ankle conditioning as well as proximal hip control and treat the kinematic chain as a whole, then you are missing the link of the puzzle. And when you do address that proximal control issues, it is, especially in an athlete, these are all developmental issues. The motor patterning happen over a period of time and years with regard to specific to what they do. So I tend to sit on the fence a little bit here.
Yeah, completely agree to Madan in this as well. But just to kind of add to why I said that it is very, very important, is specifically because as he rightly pointed out, that some people do adapt to flat feet pretty well, and they play at the highest level as well. Having said that, we are talking about a chronic ankle instability with flat feet. So this person is already having this recurrent issues. And then when the rehab is not, obviously, again, going back to working upwards, we need to understand that this might need an orthotics to help him get better, because there's already going to be an element of injury which we need to address.
Absolutely. I mean, I also agree to what Madan said as well as Ajit said. But as I said in my talk, the assessment of the foot and ankle always go hand in hand. And that's why I wanted to go down to the foot and to the ankle when I'm assessing. Once I find, I mean, you will find, I mean, in a population like India, where you will find a lot of flat feet people, we have to, not necessarily everybody would have some kind of an ankle issue, but it's an important factor to look into for sure. Not necessarily, but it is a very important factor. So I would go according to what both of them said. Yes, we will progress accordingly. The kinetic chain is the most important thing, I would say. Yes.
Thank you very much. I, of course, would find myself in agreement. As we always say, only rehabilitate what's in front of you. Don't go to a cookie, what we say in Australia, no cookie cutter rehabilitation is allowed. You have to treat everybody as an individual. So I'd like to really thank Dr. Ajit, Dr. Vaibhav, Dr. Madhan. I'm sorry if I pronounced your names wrong. And thank you all for joining our panel discussion today. And I'll hand back to Dr. Swapnil.
Thank you, all the panel members. Thank you, Claire, ma'am. It's always a treat to watch you, listen you, and keep on hearing to the comments what you give with your all the vast expertise in your all respective fields. I thank Claire, ma'am. I thank Madhan sir. I thank Vaibhav sir. I thank Ajit sir for taking out time, helping us out to have this live discussion. I can understand how much difficult it would have been for all of you to collaborate and get assimilated at one single time frame. Thank you very much.